So the topic of my presentation is stereotactic radiotherapy for hepatocellular cancer with focus on downstaging and bridging treatment before liver transplantation. For those of you who might remember exactly what is the difference between stereotactic radiotherapy and conventional radiotherapy, I have one introductory slide. So the definition of stereotactic radiotherapy is actually to give a high dose per fraction, usually above 5 Gray, to a small tumor with very high accuracy. And by doing this, we achieve actually much higher doses as we ever did with conventional radiotherapy. So we treat with a dose range that is ablative. And stereotactic radiotherapy with these high fractions also has a specific biology. For example, it activates the immune system, which is now exploited in several tumor entities, for example, in lung cancer, not yet for liver cancer, to my knowledge. And it also has an antivascular effect. So there are actually quite a few studies investigating SBRT for hepatocellular carcinoma. This is one example. So 60 patients were treated, liver cirrhosis stages A and B. The median tumor diameter was 3 centimeters. A risk-adapted treatment regimen was done depending on the liver cirrhosis stage. And you can see a 2-year local control rate of 90% was achieved. 23 patients were then transplanted during follow-up. And with regard to toxicity, there was some severe toxicity, so 2 deaths due to liver failure, and actually 8 patients with a CP score above 8. Half of these 8 patients developed some form of liver failure. So when we apply SBRT, we have to be careful about the CP score. So this is a table with retrospective studies investigating SBRT for hepatocellular carcinoma. So the median tumor size was about 3 centimeters, but there are even studies with 9 centimeter tumors. Different treatment schedules were used. So usually for larger tumors, a little bit less dose. And the biological equivalent dose, this is actually something we calculate to compare different fractionation regimens. And as you can see, if the radiation dose was very high, so biological equivalent dose above 100, then actually the 2-year tumor control rate was also very high. So really, in some studies, it was given as 100%. That's quite impressive. So extremely high local control can be achieved with SBRT, depending on the dose we give. And these are a summary of prospective studies. So clearly it's much less studies, only 5 prospective studies. The patient numbers are very small in these studies. So this is more a picture of real life. So very heterogeneous study population, and here the local control rates were a little bit less, so below 65 to 95%, and also the toxicity shown here. So there were some high-grade toxicities like ulceration of the GI tract was one toxicity, or ascites. And in one study, in case of child-abuse stage B, there was some higher, even 38% toxicity. So also when we use SBRT, we really have to be careful about the stage of cirrhosis. Now I come to stereotactic radiotherapy as a bridge to transplant. So this is the University of Toronto experience. They used bridging therapies in 406 patients out of 594 transplanted patients. So you can see here in 36 patients they used SBRT, in 99 patients TACE, and in 244 patients they used RFA. So the dropout rate before liver transplantation obviously is important. So that was very similar between the three bridging therapies. In 9% SBRT was used as bridging therapy, and similar dropout rates were observed, as I said. So the type of bridging was always discussed at the interdisciplinary tumor board. SBRT was recommended in this series if patients were ineligible for TACE or RFA due to liver function, thrombocytopenia, and for technical limitations of RNA, RFA, and TACE. SBRT was usually given in 6 fractions every other day, so after 2 weeks, patients were finished. Compared to the non-transplant patients treated with SBRT, so the studies I showed before, lower doses were often used because the patients were probably more sick, more advanced liver cirrhosis. And in some patients, only the largest HCC lesion was targeted with SBRT given the inherent poor liver function. So the number of lesions, in about half of patients, there was only 1 lesion, but in the other half of patients, there were 2 lesions or even 3 lesions, and the median tumor size was 4.5 centimeters. So as I said, in clinical routine, risk-adapted SBRT usually has to be used. This is a typical treatment plan. So in red, you see the tumor. And usually we draw a margin of 1 centimeter around the tumor. And then with SBRT, we can really homogeneously treat the tumor plus this rim around it. Here you can see the tumor after SBRT in the explanted liver. You see the necrotic tumor and also a white rim, which is the cirrhotic area. As I said, we draw a margin of 1 centimeter around the tumor, and we induce fibrosis in the tumor, or in this area around the tumor, and necrosis in the tumor. Yeah, you see the histology like the rest of the tumor, and here in blue the fibrotic area around the tumor. So these are the results of this Toronto study. Risk of recurrence. So I would say the recurrence was lowest in the RFA group. However, it was also the largest group with 200 patients. So in the risk of recurrence after SBRT and TACE was somewhat similar. So risk of recurrence about, I would say, 20 to 30%. And on the right side, you see the survival after listing. And this was actually very similar between the three bridging approaches. So I would conclude out of this study that SBRT can be safely used as a bridging therapy and is a good alternative to the other treatments. Now, this is another study, University of Rochester experience. So 60 patients were transplanted. These 60 patients had altogether 79 bridge therapies. So again, the bridge strategy or treatment was discussed at the multidisciplinary tumor board. Here you can see a list of the treatments and patients. So it was a smaller study. In this case, SBRT was the second most frequently used bridging therapy after TACE. Size of tumor was rather small, around 3 centimeters. And interestingly, the toxicity was also very low. And the high-grade toxicity was even 0% after SBRT and also after SIRT. Yes. So what we conclude is SBRT is very safe. These are the results of the bridging therapies. So radiological responses, complete response or partial response was seen in about 60% after all 4 bridging strategies, so very similar. The local control rate, so which is not only radiological response but also stable disease, was about 80 to 90%. Here SBRT was even highest, and the mean proportion of pathological necrosis in the tumor, so after in the liver explant, was 60 to 90%. And here SBRT was highest. What we conclude out of this data, all 4 treatment options are equally effective, I would say, as bridge therapy. So the most important endpoint here in this table is probably the local control rate. So with regard to SBRT technology, as you know, there are different technologies on the market. So you can do this with a linear accelerator, with a CyberKnife, or with a tumor therapy. So it's important, I think, to clearly state all 3 technologies operate with MV X-rays, usually treat with multiple beams, and there exists no evidence that one technology is superior over the others. So I come to the summary. SBRT for bridging downstaging of hepatocellular carcinoma. So SBRT results in excellent 2-year local control rates of 65% to 100%. The effect is clearly dose dependent, I would say. The toxicity is favorable with very low high-grade toxicity in patients with CP score below 8. Be careful with higher CP score. SBRT is a valuable alternative for bridging and downstaging if compared with RFA, TACE, and SBRT. However, only a few studies with low patient numbers exist comparing different bridging strategies. And probably in the real life and in the tumor board, it's always decided with regard to the patient situation and the tumor situation. So thank you very much for your attention.
Any comment and question from the floor?
I think one, for example, is the localization of the tumor. So if it's in the very centrally located or in the liver dome, I mean, for SBRT, this is easily accessible, but less for RFA, I guess. Also, if it's close to the vascular structures, to the portal vein or to the vena cava, then also probably this is difficult for RFA, but accessible for SBRT.
Do we have a tumor size, maximum tumor size limit for SBRT?
That's a good point. As I said, as I showed in one of these studies, they treated very large tumors. There is now a randomized studies ongoing in Europe comparing TACE and SBRT, and the maximum tumor size for this prospective study is 6 centimeters. But I would not say that there is an absolute limit for the tumor size. It's rather the size of the liver itself, because when we treat with SBRT, we also treat some healthy liver tissue, and we always have to make sure that, for example, at least 700 cubic centimeters of the liver are below a certain threshold dose. So because we don't want to induce liver failure, so that's more the limit, the liver size. So if you have a patient after hemihepatectomy with a small liver, we are more limited. But in a patient, for example, without cirrhosis, with a large liver, there is almost no limit.
Thank you.